I now consider the various disorders of feeding and satiety, especially the disorders associated with the feeding and satiety. These are some of the hypothalamic and some are metabolic. I talk about anorexia nervosa, bulimia nervosa, hypothalamic obesity, Pickwickian syndrome, and some of the obesities are hypothalamic. Fever and loss of appetite, again, hypothalamic centers are involved. Cachexia, hypothalamic centers are involved. So these are the disorders associated with the feeding and satiety in relation to hypothalamus. Let us see them one by one quickly. Now, anorexia nervosa. This is the disease of the current generation. Today I was just trying to talk about, I was trying to reading some news items about the African these things. In the African country, especially the females, if they are lean and thin, it is considered that they are suffering from some disease, especially the disease like AIDS and other chronic infectious diseases. For that reason, in Africa, the tendency or the fashion is to gain weight and be healthy. I use the word healthy in the sense of obese. So now, anorexia nervosa is the disease of the modern generation. And of course, the previously also there, because in the previous this thing, they were having certain this thing in psychiatric illnesses. It's a life-threatening disorder. It is characterized by self-starvation and excessive weight loss. The disorder is diagnosed when a person has lost weight. Maybe he has lost about 20 to 25% of the weight. So then suddenly you have to, because when his body weight has become around 80% or less of his normal body weight, ideal body weight for the age and sex, we have specified mammograms. So when the body weight, not for you, for your age group, for the chart, according to the chart, if there is a 20% lesser than the body weight chart, so that is the beginning of the anorexia nervosa, and we cannot have any other these things because it's only clinical. It is most often seen in females, and of course, nowadays I do not want to isolate only the females. Males are also equally responsible because they are also worried about to maintain their physique and maintain their these things, certain aspects. The risk of developing is greater. Eating disorder is greater in actors. If you see the Bollywood and Bollywood actors, if you are seeing what happens, maybe some of the actors were very lean and thin, and after their acting period is over, they become very obese. They become very obese. So you can just see that. You can see the older actors in their earlier pictures, and after they have become the actors, the models, the dancers, the athletes, especially the weightlifting and other things, they have to maintain particular weight range. So where that becomes a very this thing, and they will develop this anorexia nervosa, and especially the boxing, gymnastic, and figure skating. So these are the professions in which they are more subjected. Otherwise, it is most common in females because they are weight conscious. They try to be look beautiful. They try to maintain their figure, and for that they will try to compromise. This can lead to dangerous and health problems. So the weight gain, suddenly what happens? They don't want to eat anything, just like that cat which I have seen, and they will just starve to death, and they will become a skin and bone altogether. A disordered attitude towards eating, food or weight, and they just don't feel the hunger because they want to this thing, and they will do a lot of exercise, that is energy loss, and because of these things there is a development of amenorrhea, that is the loss of menstruation, menstrual cycle. Then bradycardia, that's cardiac problem, hypotension, because there is nothing is there. Then hypothermia, because the metabolic rate is decreased, and this would be very, very severe. The patients with anorexia are vulnerable for sudden death because of the ventricular tachyarrhythmias. Now, there is no specific treatment. You have to go for the psychiatric counseling and psychiatric treatment, and then you come back to normal. And you be what you are. You are a unique piece on this earth, and you try to be what you are. That is the message for the anorexia nervosa patients. Okay. Now, there is another condition. These these anorexia nervosa patients are emaciated, skin and bone, and they are weight loss. Here we have another eating disorder. It is called a bulimia nervosa. Bulimia nervosa is associated, again, it is common in females. It is considered to be a part of the anorexia nervosa, but it is different because here the weight is normal or in the obese side. It is characterized by what is the in the anorexia nervosa patient is not eating. Here the patient have a binge. That means he eats sometimes compulsively binge eating, like a hungry dog or hungry whatever ox hunger. So they eat, and once they eat, they become aware. Okay, I have eaten too much today. What to do? So they vomit it out. They purge it out. So they try to throw it out. So that is what the behavior of the bulimia. They keep eating because they want to have the hedonic pleasure of eating food, or they eating food in a compulsive manner. And then once stopped, they will throw it out by vomiting, using vomiting agents, or even purgatives, take purgatives and throw. That means go for the loose motion. So they have the feeling of they become very fat, though their normal weight is normal, and it is induced by vomiting, I mentioned, and or by putting a finger in this thing and throw it out, and have a other psychiatric and behavioral abnormalities in bulimia nervosa. Now, little more about the bulimia nervosa. So the serious and sometimes life-threatening eating disorder affects mainly young women, consume large amounts because they eat food, that is large amount of food, that is binge, and then they try to rid of themselves by purging, or by fasting, or by exercise, or by vomiting, or by using laxatives. The behavior often serves to reduce the stress and relieve anxiety. Sometimes the binge eating is to get the pleasure because you are stressful, you keep eating. So relieve the stress, you may do that, or maybe because of the anxiety. Because of bulimia results in excessive concern with weight control, because they are self-conscious, they are perfectionist, they try to have the body image, and they are trying to, and then they become depressed, and they will end up with some psychiatric illness. We don't know the cause of the illness of this bulimia. Genetic and environmental factors are suggested. It runs in families, and it has certain psychiatric disorders associated with, especially obsessive compulsive disorders. The environmental influences, that means include a participation in work, sports, especially I mentioned about the sports there, the modeling, dancing, gymnastics, and that's where they emphasize to maintain the weight. So, or there are family pressure. The parents or mother is all the time telling the daughter that you are obese, you are obese, you are obese. Then she will end up with that. Or a younger brother is there, he all the time teaching the sister, or family pressure. So like that, and they play a role in this bulimia nervosa. So what is that? We need to counsel them. The nutrition counseling is helpful. Antidepressants commonly used to treat this bulimia. Mostly the counseling of the patient, and telling them that be what you are. You enjoy your life, and this life is only once, and something like that. We have to assure them, and you have to not only the patient, even the entire family, the mother, father, and brother, the siblings. They also to be told that don't tease her, don't make the pressure, so that this bulimic person gets out of that, and he may come out. Then we have another condition called I'm going in the reverse direction now. Now we were thinking about the weight loss. Now we look into the obesity, hypothalamic obesity. I'm just mentioning, I will come back to the obesity in the next slides. This hypothalamic obesity occurs in patients with the tumors and the lesions in the medial hypothalamic region. That means the dorsomedial nucleus or the ventromedial nucleus, which are maintaining the satiety center. The structural damage to these nuclei often lead to hyperphagia, rapid weight gain, and also they will result in insulin resistance and leptin resistance. Sometimes it may be independent of these lesions, insulin and leptin resistance, and that will decrease the sympathetic activity. Decreased sympathetic activity is the decreased energy consumption, and that will increase the adipose tissue generation. Treatment is not very satisfactory. We have to find out the cause. We have to find out what is wrong in the hypothalamus, and which has produced the medial hypothalamic region. Maybe tumor pressing there. You remove the tumor, it may relieve. It may offer the relief. These patients have substantially reduced quality of life with high rate of stroke and cardiovascular mortality. These hypothalamic patients, they are either having cerebrovascular accidents or cardiovascular accidents, ischemic diseases of the cardiovascular or cerebral disorders. There is one more specific hypothalamic obesity, which is known as a Froehlich's syndrome. Froehlich's syndrome, maybe these are for a short note question. It is characterized by obesity, hypogonadism, because this is resulting from the decreased gonadotropin secretion, and other variable features like diabetes insipidus, that means posterior pituitary is involved, the visual impairment, maybe chiasma is involved, and a mental retardation. So this is a Froehlich syndrome, hypogonadism, and includes diabetes insipidus, the visual impairment, and a mental retardation. It is thought to be due to the result of the hypothalamic lesions. This is about hypothalamic obesity. Then one more peculiar condition about the hypothalamus, this is called a Pickwickian syndrome. This Pickwickian syndrome, it is also called obesity hypoventilation syndrome. Obesity hypoventilation syndrome, it is a short note question. Is defined as the presence of alveolar hypoventilation. Alveolar hypoventilation when the person is awake, characterized by a daytime hypercapnia, arterial PCO2 less than 45 millimeters of mercury, and it is due to the decreased ventilatory drive to obesity in the absence of neuromuscular or mechanical or metabolic explanation for the hypoventilation. The neuromuscular means if there is a neuromuscular failure, there is a hypoventilation. Mechanical means if there is obstruction, there is a hypoventilation, or the carbon dioxide accumulates. Or metabolic, there is increased metabolism, there is a decreased metabolism, there is a hypoventilation. These individuals are having a BMI, body mass index, I will come back to that subsequently, greater than 35. And this is because of that that will produce hypoventilation syndrome. Let us see it a little more. This Pickwickian syndrome is attributed to the combination of the failure of respiratory pump and respiratory center. Respiratory pump because of the mechanical hindrance caused by the obesity. Respiratory center because of the attenuation of the central chemoreceptors to the carbon dioxide, because the central chemoreceptors are sensitive to the carbon dioxide, PCO2, and attenuation of the or blunting of the responses to the PCO2. So these two things, and they are manifested with sleep apnea syndrome, that is the sleep disordered breathing, or impaired pulmonary mechanics. So you have the impairment of the um, when these tidal volumes and the vital capacity and all other the pulmonary function tests. The blunted respiratory drive, as mentioned here, and in addition, they are associated with the leptin resistance. So this is a Pickwickian syndrome. So these are attributed to, because then investigations, there is a hypercapnia. You will see the PCO2 levels are uh, the more loss of carbon dioxide. That means hypocapnia here. Hypocapnia is that it is a hypocapnia, hypoxemia, polycythemia, and restrictive pulmonary function tests. And there is a altered polysomnography and pulmonary hypertension and right heart enlargement and right heart failure. That would be the investigations. The treatment is to treat the obesity, because this is associated with the persons with the BMI greater than 35, and give them assisted ventilation, because the ventilation improves the carbon dioxide elimination, and the oxygen inhalation therapy will be helpful. This is about Pickwickian syndrome. So again, if I say that, so this is a hypercapnia. So that means the hypoventilation, but there is a hypercapnia in the Pickwickian syndrome. There is a more carbon dioxide in the body because of the respiratory pump failure, because of the obesity, or a respiratory center non-responsiveness to carbon dioxide. So you will find all those hypercapnia, hypoxemia, polycythemia, and all those things coming up there. Now coming about the obesity, I will quickly go through it, and this is whatever I am presenting here will be understandable and easy to follow. Obesity is a complex disease involving excessive amount of body fat and can be defined as a multi-metabolic hormonal disease. Multi-metabolic hormonal disease. Here, the calorie intake is greater than the output. Now, because of that, there is a storage of the whatever the calories as fat in the adipose tissue. I will not go into the details of the obesity because it is a very important burning topic to all of us. So, but anyway, I briefly mention obesity is diagnosed when the body mass index is greater than 30. What is body mass index? Maybe you all know. So body mass index is equal to weight in kilograms divided by square of the height in meters. This ratio, you try to figure out your own body mass index today. Try to know where do you fit in and where you are. So weight in kg divided by square of the height in meters. So if you are less than 18.5, you are underweight. Then you are free to eat. If you are in this range between 18.5 to 25, I just say 25 there, 24.9, you are a normal range. So try to maintain that. Now, if you are greater than 25, lesser than 30, so you are overweight. So that means potentially you are going to be obese. So that means you have to see, that means you are crossing here the obesity threshold. Now, greater than 30 is diagnosed as obesity. Now, looking back with the BMI and the Indian population, there are certain norms. So now, if you are looking at this is international standard, whatever I mentioned. So less than 18.5 underweight, 18.5 to 24.9 normal, pre-obesity 25 to 29.9, it is pre-obesity, that means you are overweight. So then obesity is 30 to 35, 35 to 40, 40 above. Class 1, class 2, class 3. Class 3 is severely or morbid obesity. Now, For us, this is for the European or the American, these things, Afro-American people. Now, for Asians, it may not be applicable, wherein our body structure is different. And in case of India, it is 18.5. Okay, it is fine. Here, the cutoff point is not 24.9, 23. Two less, 23 is normal. 23 to 27.5 is what I say. If you are more than 23 and less than 20, so you are overweight. So then above 27.5, you are obese. Now, if you are looking at the health risk, your risk for the nutritional deficiencies, these underweight persons are risk, they have a risk for a nutritional deficiency and osteoporosis and other diseases. So these are normal individuals. I don't think we are having other risk like a risk for COVID-19 or whatever. So this is a moderate, these persons are moderate risk with a cerebro cardiac abnormalities. These are high risk patients or persons. Now, what causes the obesity? We don't know. Environmental, genetic, inflammatory, and metabolic factors are postulated. If you can just look at this, the hypothalamus regulates the energy balance, receiving inputs from the periphery and triggering efferent or effector organs for neurohumoral activation to burn the calories. So complex interplay of GIT hormones, the cytokines, the mediators from the adipose tissue provide relevant signals to the hypothalamus, especially the nerve in the nervous system, which regulates satiety and adiposity. So leptins are there, no? So that secretion of the orexigenic or anorexigenic peptides. So where that is linked with hypothalamic center is linked. In obesity, there is a derangement of this regulatory function. There is a derangement of this regulatory function, and the person goes for eating because there is some satiety abnormality. This leads to inappropriate expansion of the adipose tissue and this hyperproduction of adipokines. More adipose tissue is made, and that is some other inflammatory cytokines are coming out. Now we look into this thing. I have taken it from the clinical science, Mirthan. You can just see that in how the obesity develops. So here I like this quote: "Obesity protects obesity." That means obesity leads to obesity. Now come back here, trying to see this gentleman in this thing. So there are anorexigenic hormones. So that means there is a decreased leptin level because the leptins inhibit. They are activating the anorexic pathway, and if they are not activating the anorexic pathway, so they will increase the eating. So decrease the leptin levels, decrease the PYY levels, decrease the CCK levels, decrease the GLP levels, and decrease the insulin. That means insulin resistance. All these things are anorexia, anti-anorexigenic. Decrease the anorexigenic activity. One point. The second point, they increase the ghrelin levels. Ghrelin levels enhance the eating behavior. So that means orexigenic. Then third component, there is always a hunger, increased hunger, and increased hunger for all those foods which are calorie rich or calorie dense. So that means this is social or behavioral eating disorders. Then come here on the last side, they will decrease the fat oxidation. That means fat accumulation is enhanced and increase cortisol. Cortisol enhances the fat accumulation. The nervous system, the satiety nervous system decrease the satiety nervous system activity and increase the mesolimbic reward centers. So that means this is decreased. So decrease the satiety. So that means increase the feeding. So all the energy expenditures associated with other hormones, especially the thyroid hormones, they are all decreased. So that means this side is down, this side is up. He's going for increased body weight. That is the cause of the obesity. Now, coming back here with the hypothalamus, these are alterations in the genetic expression of the melanocortin secretion, MC4 receptors, alteration in the leptin gene, so that means leptin receptors under expression. If the leptin receptors are underexpressed, especially with AGRP neurons, so that means that will keep on stimulating. Or they're more overexpressed the pro-opiomelanocortin gene, so that the other side, opposite side, this is inhibitory, this is satiety, this is satiety. So that means that will increase the underexpression, that means that will increase the activity, no satiety. Agouti increase the expression, the feeding behavior. So these are some of the genetic causes which produces the obesity. I will not go into the details of that. So now, what are the problems with the obesity? So I have a list. I am trying to abridge the list. I just read them out. Reduced life expectancy and the low quality of life. That is one point. And the obesity is a comorbid situation for all illnesses. If you are looking at the one of the comorbid conditions for the COVID-19, obesity is one of them. They are more vulnerable people. And obesity produces hypertension. So for every kilogram body weight, there is 1 millimeter blood pressure increases. So you can open up the Harrison's textbook of medicine and you can get that. So that means if you are having weighing more weight and your blood pressure increases, it produces hypertension. And dyslipidemia, that means there will be enormous accumulation of the lipid or the adipose tissue, and this is reflected upon your triglycerides and other cholesterol levels. It produces the type 2 diabetes, and the insulin decreased insulin sensitivity, what we call it as a insulin resistance. This is also known as a metabolic syndrome or insulin resistance syndrome. And this poses a threat to the coronary heart disease and cerebrovascular accidents, stroke. This increases the formation of the gallbladder diseases, cholecystitis, gallstones, and cancer of the gallbladder. Now, osteoarthritis because of the heavy weight, sleep apnea syndrome, infertility and reproductive hormone diseases, malignancies, that means cancers, breast cancer, endometrial cancer, the cancers of the stomach, the liver, gallbladder, kidney, and so many. The mental illnesses because of the weight, the depression, anxiety, other mental disorders. And all the time this person is having body pain and difficulty in physical functioning. He become more and more lethargic. He keeps on eating more and he adds and he goes on and on and on, and he will become very big. Okay, so now that is about the health risks of the obesity. I will not go into detail, and I am trying to trigger you all to be healthy. Now, evaluation and treatment, I will not go detail because this is not here. Investigate the individuals for metabolic, endocrine, inflammatory, and genetic causes. Treatment, target the specific agent. Suppose if there is a metabolic defect, you try to correct that, or endocrine defect, try to correct that, and then, or inflammatory or whatever, you try to correct that. The counseling of the individual, and especially the counseling in reference to the weight gain, how he wants to control. Then diet and exercise, those are to be given, and the drugs that lower the cholesterol or the lipids, or increase the leptin levels, or stimulate the POMC neurons. That these are anorexic neurons. Then the last but not the least, maybe I don't know, Adam Sami, or that Pakistani singer. Now he has become Indian national. The Lift Karado. That is the song he has made, and he was so obese. Now he has become trimmed. So he has undergone this bariatric surgery. Bariatric surgery is the surgery which they do in such a way that they reduce the weight gain, and liposuction. These are the surgical treatments for the obesity. Now, briefly about fever and loss of appetite, because this is one of the symptoms we get it. This is called inflammatory anorexia. This is a protective response because it prevents further ingestion of those potentially toxic or contaminated food. Second, it decreases the basal metabolic rate and lower the temperature. Lower the temperature. So lowering of the temperature, that will decrease the that will try to make it lower the food intake. Then sends the use of energy storage, because by stopping food intake, the energy storage is used purposefully to the immunological system, rather than, because if you start eating, this will be diverted for the digestive actions. So it is to send this from digestive related between enzyme secretion, the gastrointestinal motility, and so on, that would send to this protective, and it reduces the nutrient content of iron and zinc and other minerals which are necessary for enzymatic activity, which help the organisms to grow. So these are the four items by which the appetite is just like a fever is a protective response. Similarly, the loss of appetite or anorexia is a helping the fever to reduce. Further, it is mediated by cytokines and bacterial or tissue toxins and prostaglandins. This is what it is due to and they will suppress these cytokines and the bacterial tissue toxins and prostaglandins. I will go with the next slide. You will know that now they will suppress they will suppress these AGRP neurons, these cytokines, inflammatory cytokines. They will suppress these AGRP neurons, and these are the feeding neurons, and they will activate these um, anorexic neurons, that is POMC neurons, they are satiety neurons. So thus they will bring in the whatever. Now I have another terminology, what is called cachexia. This is the last one. Loss of muscle mass accompanying the involuntary weight loss in chronic diseases known as cachexia. It is a loss of muscle mass along with the other. The consensus definition is complex metabolic syndrome associated with the underlying illnesses, because you have a cancer or tuberculosis or something, underlying illnesses, and characterized by loss of muscle, what is called sarcopenia, and with or without loss of adipose mass or adiposity. So that means the loss of muscle tissue without with or without the loss of fat mass. That is cachexia. And these individuals, when they are having a prolonged illness like a cancer or the chronic infections, they will become emaciated. They will become emaciated. The presence of cachexia is a negative prognostic indicator for in conditions, because if you have a cachexia sets in, and this is the mechanism why the cachexia comes in. I will come back to that. So that will be a bad sign for the diseases like a cancer. That means he is going to further. That means his days may be counted. Renal failure, his days may be counted. Or congestive heart failure, that is a bad sign for the individuals, or this HIV infection. So that means cachexia is one of those conditions. Is attributed to inflammatory cytokines which suppress AGRP neurons and activate POMC neurons. This is inflammatory cytokines here, and these inflammatory cytokines which are released, they will suppress this AGRP neurons, and once they are suppressed, what happens? The anorexic neurons are activated, and they will become this thing, and that is what I have mentioned here. The one side it suppress inhibits it, one side it activates it. That's how these inflammatory cytokines work in. So this is about cachexia, and is not always associated with anorexia, but they often happen together. Unlike starvation, suppose if you are thinking that it is because of the starvation, no, where adipose tissue is predominantly lost. In case of starvation, this is the adipose tissue, fatty mass is lost, the muscle mass is the last one in case of starvation. and adipose tissue are both affected. Muscle mass and adipose tissue both are affected in cachexia. Correction of the nutritional deficit by intravenous nutrition and prevention of catabolism are strategies for the treatment of cachexia. But you have to look into these the conditions which have led to the cachexia, that may be cancer, infection, or other chronic disorders that has to be looked into. Well, these are the keywords for today's lecture. I just mentioned them. These make the short notes for these things because I'm not giving you any assignment. Acute nucleus, ventromedian nucleus, lateral hypothalamus, paraventricular nucleus, dorsomedian nucleus, satiety center, alpha MSH, ghrelin, AGRP neuron, POMC neuron or a CART neuron, obesity, anorexia nervosa, bulimia nervosa, Pickwickian syndrome, orexinergic factors, anorexinergic factors. So these all I have covered. You try to look into them, and so that would give you. I have covered two topics today. One topic about obesity because that's very important, and because not only important for the physiology examination as a physician tomorrow if you are going to be, and that would help you there, and the hypothalamic regulation, the entire the feeding behavior. Now, the next time I think I will take up the thirst and water regulation. I have already partly covered the thirst and water regulation in some of my lectures. Now I will take on this next lecture.